Today we are going to discuss about the complete heart block or the third degree AV block. Complete heart block or third degree AV block. In the previous two lectures, we have covered first degree heart block and the second degree heart block, which has got two types, type 1 and type 2. And this AV block, this AV stands for the Atrioventricular Node. So before we go on further, we should first understand the role of the AV node and the way the conduction system of the heart works. Let's draw a diagram regarding the conduction system or electrical pathway of the impulse transmission of the heart and the role of the AV node in that transmission and the role of the AV node in the generation of a normal ECG. So if we draw the normal conduction system of the heart, two atria are located right above two ventricles, and this septum, this is the interatrial, and this is the intraventricular septum, which separates the two components, both the atria and both the ventricle from each other. Normally, SA node automatically generate impulses at a rate of 60 to 90 times per minute, and these impulses pass through Bachmann tracts and they enter the atrial muscles, and they cause the depolarization of the both atria simultaneously, and it generates P wave on the ECG paper. Now from atria, these impulses pass through the AV node. AV node or the atrioventricular node is located at the junction of the atria with the ventricles. This is the only part of the conduction system through which impulses can pass from the atria to the ventricles. Rest of this part of the heart, which separates the atria from the ventricles, doesn't allow the impulse to pass through it. So from the AV node, this impulse comes downward and it enters bundle of His. The path of the electrical impulse through the AV node, it is represented on the ECG paper with the help of, so this part of the impulse transmission through the AV node is represented on the ECG paper with the help of the PR segment, which is from the start of the P wave to the start of the QRS complex. From the bundle of His, this impulse travels into the both right bundle branch, left bundle branch, which has got a posterior fascicle and anterior fascicle, and the septal branch. So the right bundle branch, left bundle branch have got Purkinje fibers at their ends, which are embedded into the ventricular muscle, and these ventricular muscle are then depolarized, and this generates a QRS complex. Then there is repolarization of the ventricular muscle, which generates a T wave. So this is P, this is Q, R, S, and this is T. So this is the conduction system of the heart, and this is a very important role of the AV node, which is atrioventricular node and is located between both the atria and ventricle. So when we'll talk about the complete heart block or the third degree AV block, then we'll be confining our discussion to the atrioventricular node. Now this is the conduction system of the heart. Here we see that in a normal ECG tracing, P wave is present before each QRS complex, and this association is actually maintained because first atria depolarize to generate P wave, then ventricular generate to create QRS complex on the ECG tracing, and there is an association which we actually understand with the help of the normal sinus rhythm, that P wave is either married to QRS complex or is associated with the QRS complex. And this is the normalcy against which everything happens in case of the complete heart block. If I draw a normal ECG tracing and we assume that this door is working very fine, it is allowing each impulse coming from the atria going all the way down to the ventricles, and there is no pause in it, there is no problem with it. The door is fine, the AV node is working as a healthy entity of the conduction system. Then how would look the normal ECG? I'll draw first the normal ECG, then I'll explain what happens if that door is completely shut. What will happen in that? Okay, now if you look at this thing, this diagram here, everything is happening very smoothly. Here you see P, this is QRS complex, this is T. This is P, this is QRS complex, this is T. This is P, this is QRS complex, this is T. In all of the tracing, you see an association. You see as if the P is married to the QRS complex. So this is P, this is QRS complex. So normally what happens, that sinoatrial node, which is located in the right atrium at the point where superior vena cava enters into the inferior vena cava, these automatically generate impulses which enter into the atrial muscle through the Bachmann tracts, and these cause the atria to depolarize. And when the atria is depolarized, it generates a P wave on the ECG tracing. This is what you see, P wave. So from the atria, this impulse enters into the ventricle through a door which we call AV node. This is atrioventricular node. It delays the impulse transmission from the atria to the ventricle very briefly, which generates a PR segment on the ECG, and PR segment is from the start of the P wave to the start of the QRS complex. This is PR segment. Then it regains its speed and enters into the bundle of His. Here in the bundle of His, it then enters into the three branches. One is the septal branch, one is the right bundle branch, one is the left bundle branch. But this left bundle branch, it subdivides into left posterior fascicle and left anterior fascicle. And at the end of both the right bundle branches and left bundle branches, we see these Purkinje fiber, which are embedded into the ventricular muscle. These cause the ventricular muscle to depolarize, as a result of which we have QRS complex. Then this ventricular muscle, when repolarizes, it generates a T wave. So in normal happy days, P is in a wedlock with the QRS complex. P is married to QRS complex and is associated with this, is actually moving along with the QRS complex all the time. So this is what happens normally. This is when we are talking, there is no complete AV block. So this is what happens in the absence of complete AV block. What will happen in the AV block? That this AV node will shut down. It will not let the impulse travel through it. Impulse will not be able to pass from the atria to the ventricle. But keep one thing very important in the mind, that the generation of the P wave has got nothing to do with the AV node. This is an event which happens well before the entry of the impulse through the AV node. So P will be generated at a rate which is dictated by this SA node. The problem is with the entry of the impulse from the atria to the ventricle, an event which is happening after this generation of the P wave. This is a very important point. So P will be generated at a rate which is caused by the SA node or the sinoatrial node. The problem is with the running of the ventricle. Initially it was the SA node which was calling the shots, which was actually directing the ventricle to depolarize at a certain rate. Now it will change forever. There will be no connection between the atria and the ventricle. This is known as complete AV block. And before we go to the pathology and its understanding, we will have to understand that there is not only a single pacemaker of the sinoatrial node, there are other two pacemakers in the body. Let's draw a diagram regarding the remaining two pacemakers in the heart. Now look at this diagram. It explains one very important fact, that normally when we talk about the pacemaker of the heart, we think that SA node or sinoatrial node is the only pacemaker of the heart, which is running the heart. But it's not the fact. Actually, there are three pacemakers in the heart. But why the rest two, they are dormant? Because SA node is firing more in number, and heart or the left ventricle is happy with the performance of the SA node. So it gives SA node that much importance that the rest of the two, which otherwise fire at a rate lower than the SA node, they remain dormant as long as there is not an emergency situation where the impulses coming from the SA node, they cannot reach down to the ventricles. Only then either of those two dormant pacemaker of the heart will start functioning and taking over the control of the ventricular depolarization and the contraction. So in order to sustain life. But otherwise normally SA node is calling the shots. So let's see what are the other two pacemaker of the hearts which are dormant, and at what rate they fire, and what is the status of the QRS complex in those pacemakers. This is very important because before we go for the further understanding of the complete heart block, we should have this concept very clearly. Let's see. This is SA node, and this pacemaker is SA node pacemaker. Its rate is 60 to 90 times per minute. It fires at a rate of 60 to 90 times per minute, and the QRS complex generated as a result of the impulse coming from the SA node is narrow QRS complex, which is less than 3 small boxes or less than 0.12 seconds. Then comes the AV nodal or junctional pacemaker, which is located at the junction of the both atria and the ventricle in the position of the AV node. It fires at a rate of 40 to 60 times per minute, so less in number than the SA node pacemaker. And the QRS complex is narrow, again less than 3 small boxes or less than 0.12 seconds. But if there is a situation to sustain life as a last resort, if both of the above lying pacemaker they cannot function to sustain the heart or to run the ventricle, then ventricle has got its own pacemaker, which we call his Purkinje or ventricular pacemaker. The lower part of the Purkinje bundle of his, and this bundle branch and these Purkinje fibers, which are embedded into the ventricular muscle, they start taking over the ventricle, and they themselves start generating depolarization of the ventricular muscle at a rate of 20 to 40 beats per minute, and QRS complex is broad. QRS complex is more than 0.12 seconds or more than 3 small boxes. So these are the pacemakers of the heart, but because normally this impulse is coming downwards, there is no problem with the AV node. So this left ventricle, which is the most important part of the heart when it comes to the generation of the blood pressure and functioning of the heart, this ventricle is very much happy with the performance of the SA node, and it doesn't let these two pacemakers take control of the SA node. So these two remain dormant as long as there is no blockage of the AV node. So when there is a blockage or complete cut off or shutdown of the AV node, this is the only time that when there is control of these dormant pacemaker depending upon the level of the block in the AV node. So what happens in the complete heart block? Complete heart block will not affect the P wave. P wave will be at a rate as it was previously, because P wave is being generated by those impulses which are coming from the SA node, and it is because of the atrial depolarization, an event which is happening before the happening of anything with the AV node. So in complete heart block, P to P rate will be normal, and let's see how the then ventricle tries to sustain. But the one thing will happen, that marriage will end. The marriage which was associating P with the QRS complex, now it will end, and both the atria and the ventricles, they will be on their own. Why? Because initially at a rate of 60 to 90 times per minute, both the atria and the ventricle were depolarized. But this time around, atria will be depolarizing at a rate of 60 to 90 times per minute, but ventricle will be depolarizing either at 40 to 60 times per minute or 20 to 40 times per minute. So this time around, P will have no correlation whatsoever with the QRS complexes. The first thing which should come to our mind whenever we are trying to find out whether this is a complete heart block or not, that there should be a disassociation. There should be a lack of correlation between the P and the QRS complex. P will lose its association with the QRS complex. P and QRS complex will be divorced. They'll be living their independent lives depending upon the sustainability of the pacemaker for the ventricle, whether this is the junctional or the ventricular pacemaker. So this is a very important concept. In the next diagram, we'll try to understand how the ECG tracing will look in case of the complete heart block. And this complete heart block can happen in myocardial infarction, in electrolyte disturbances, because of certain drugs. For example, if a patient is put on the beta blocker and diltiazem or verapamil both at the same time, it will cause the complete heart block because these both are AV nodal blocking drugs. And say for example, there is a patient who's got nephropathy, is put on the ACE inhibitors and is also taking spiromide and hasn't got his renal function and electrolyte test done in the last 6 months. Patient would be hyperkalemic most probably, and hyperkalemia again causes the complete blockage. So there are many causes which can be dealt according to their diagnosis. The ECG tracing will be very specific. How? There will be no association between the P and the QRS complex. QRS complex can be narrow or broad. Narrow in case the pacemaker which is active is junctional pacemaker. Then it would be at a rate of 40 to 60 per minute. And QRS complex will be broad if the pacemaker which is activated is the ventricular pacemaker. Then it would be at a rate of 20 to 40 times per minute, and QRS will be broad. It will be more than 0.12 second. It will be more than 3 small boxes. So ECG criteria is no association between the P and the QRS complex, and the rate of the ventricle will be less than the P rate. P to P interval will be regular and R to R interval will be regular, but no correlation between the P and the QRS complex. Let's draw these diagrams. If you look at this diagram, this is a case of a complete heart block or third degree AV block. This AV, atrioventricular node, is completely blocked. It's not letting the impulses generated by the SA node to pass through it and to go downwards to the ventricle. So what happens there? That SA node is firing at the previously normal rate, at a rate of 60 to 90 times per minute, and those impulses are passing through the Batchman tracts. They are going into the atrial muscle, causing them to depolarize, and which is generating P wave as it was normally producing previously. At a rate of 60 to 90 times per minute, these P wave are being generated at a rate of firing of the SA node. Now because AV node is blocking the impulse transmission downwards, so this bundle of his upper part, which will be a junctional pacemaker, will be activated. This is the blockage here. Now here the part which is on the below the AV node, the part of the lower part of the AV node and the upper part of the bundle of his will start its own pacemaker, which is known as junctional pacemaker. Now we have already discussed that this pacemaker is firing impulses at a rate of 40 to 60 times per minute, and they are creating a narrow QRS complexes. So here, look at this. This is a narrow QRS complex, and the rate will be 40 to 60 beats per minute. Now I have separately drawn the P wave and then the QRS complexes. Now, but we don't see on the ECG paper this separation, but these are actually mixed because ECG is nothing but an event recorder. So it's recording the depolarization of the atria and depolarization of the ventricle, though independently, but it will have to produce the result in the form of the recording of the both of these depolarization, and it will be a mixed picture then. This P will be present here, it is present here, it is present here, it is present here, here it is embedded in the R wave. Here you see that there is no correlation between P and the QRS complex. So they have lost the association. It's complete disassociation of the atria and the ventricle. So P to P interval is regular, R to R interval is regular, but there is no association between the P and the QRS complex. And in case of the junctional pacemaker, it's a narrow QRS complex. It's a narrow, but the rate would be around like 40 to 60 times per minute. It may be like in this tracing I would have drawn it like nearer to each other, but it will be 40 to 60. No association between the P and QRS complex. P to P interval will be regular, R to R interval will be regular. I have separately drawn because SA node is causing this depolarization in the P wave, but junctional pacemaker is causing the ventricular depolarization and the QRS complexes. So there is complete disassociation. So this is a complete heart block where a junctional pacemaker is active. Now we will draw another diagram where the blockage will be even at this lower part. The lower part of the AV node and upper part of the bundle of his. So the junctional pacemaker will also be mute, will not be able to take control of the ventricular depolarization. It will only be left to the ventricular pacemaker, which is these bundle of his lower part and Purkinje fibers and the ventricular muscle. They then start firing through their own pacemaker, which generates QRS complexes at a rate of 20 to 40 beats per minute, or 20 to 40 QRS complexes per minute, and the QRS complexes would be broad. Let's draw that diagram. Now if we look at this diagram, here we see that again this is a complete heart block. This is a 3rd degree AV block. This time around the block is at the level of upper and the lower part of the AV node. Both the completely AV node is blocked, even the upper part of the bundle of his is blocked. So junctional pacemaker cannot be active. Because junctional pacemaker cannot be active, the only leftover option is the ventricular pacemaker. The ventricular pacemaker is actually located at the level of the Purkinje fibers and the ventricular muscle. It causes impulses at a rate of 20 to 40 times per minute, and it generates a broad QRS complexes, which is broader than 3 small boxes are 0.12 second. So here we see that P wave is being generated by the SA node. P wave is being generated by the SA node at a rate of 60 to 90 times per minute. So it is not affected by the AV node blockage. But now the ventricular pacemaker is active at a rate of almost 20 to 40 times per minute, and QRS complex is broad. But there is no association or correlation between the P and the QRS complex. I have drawn these two events independently. P is independent of the QRS complex at a rate different, because these respond according to their pacemaker. Like ventricle responds according to the ventricular pacemaker, and SA node is dictating the P wave number and the frequency. So I have drawn these two events independently because they are happening independently. But the ECG paper, as I already told, it's an event recorder. It's not doing anything thinking that there is no correlation between the atria and the ventricle and the P and the QRS complexes. They are coming independent of each other. But even if the P wave falls on top of the R wave, like the atria is depolarizing all at the same time when the ventricle is depolarizing, ECG paper will only show two events altogether. For example, if you look at here, P wave is here, this is here, this is here, this is here. It's irrespective of where the R wave is actually falling. So R to R is regular, P to P is irregular, but there is no correlation between them, and the QRS is broader, is around like more than 0.12 second or more than 3 small boxes. So this is what happens when in the complete heart block, when the ventricular pacemaker is active. So now we will talk a little about the management of the complete heart block. Before we jump onto the management of the complete heart block, first we will see what are the causes of the heart block, why it happens. There are three major causes of the heart block. One is the drugs. In the drugs we have calcium channel blockers, and most important are diltiazem and verapamil. These are two calcium channel blockers which are very much familiar, known to the doctors when it's one of the causes of the complete heart block, because they block the AV node. Then there is beta blockers like metoprolol, and it's also AV nodal blocker. And one thing which is very important to be remembered is that never ever give a calcium channel blocker of these two types and beta blockers together, because it increases the chances that the patient will ultimately develop complete heart block. Then there are antiarrhythmic drugs like the amiodarone, which we use in Pakistan with the name of the cardarone. It is also a AV nodal blocker. It can also cause the complete heart block if there is any other associated factors of it. Now, then there is a severe electrolyte disturbance, which is most important, is the hyperkalemia. In most of our day-to-day or the practical ICU work, we receive most of the patients who are taking either some calcium channel blocker, beta or beta blocker, and also they are taking some ACE inhibitors and potassium sparing diuretics, and patient are having a nephropathy. All of these things actually predispose patient to develop hyperkalemia, which also causes the complete heart block in those patients. Then there are myocardial infarction. Inferior wall myocardial infarction causes blockage at the rate of at the higher location in the AV node. So junctional pacemaker is very much active, and in case of the junctional pacemaker, chances of patient survival without any intervention are more than the other cases. So inferior wall myocardial infarction, most of the time patient can be managed within 2 weeks, and there are chances that patient will revert to the sinus or the normal rate in case of the inferior wall MI. But inferior wall MI does cause complete heart block at the level of the AV node's upper position, so the junctional pacemaker is active most of the time. But anterior wall MI, in which case the left anterior descending artery is involved, is a very sinister example, because it can cause the complete heart block, AV nodal block, to the extent that only the ventricular pacemaker is active, and these patients without intervention can die. So these are most important causes: drugs, electrolyte disturbance, and myocardial infarction. These patients present with dizziness, irritability, syncope, chest pain, shortness of the breath, and these symptoms are mostly associated with the hemodynamic instability of the patient. Namely, BP can be systolic BP less than 90 millimeter of mercury, and patient can be in the bradycardia. Heart rate or the ventricular pacing can be a rate less than 60 times per minute. So these are the major clinical presentation of the patient. When you check the pulse of the patient, it's bradycardic, and patient is most of the time either quite confused, disoriented, complaining of the chest pain because it may be associated with the MI. Patient can be drowsy because patient may be in acidosis because of some nephropathy, which is aggravating the hyperkalemia and causing the complete heart block. Now this is a complete heart block or third degree AV block with junctional pacemaker activation, narrow QRS complexes at a rate of around 40 beats per minute. This is another example of a complete heart block or the third degree AV block. No P association with the QRS complex. P and QRS complexes, they are being recorded independent of each other, and this time this is the ventricular pacemaker which is active. You can appreciate that the QRS complexes, they are broad. R to R interval is regular, P to P interval is regular, but there is no association of the P with the QRS complex. P may be anywhere, even in the QRS complex.